So I think there's several lines of evidence that support what you choose. So if you've got a good risk patient by MOTSA or international criteria, I think the standard is still a TKI, because sunitinib is actually shown in comparison, for example, with nivolumab and ipilimumab, that in that setting it's a better agent than that combination. And so from that perspective, I would still pick a TKI in the majority of patients who have good risk first-line renal cell cancer. I would choose in those patients between sunitinib and pazopanib, where the COMPAS trial suggested they were similar in terms of outcome. For a patient that's got intermediate or poor risk, I think we now have a choice of whether we would give another TKI, cabozantinib, that targets not just VEGF but also MET and AXL pathways, because there was a benefit over sunitinib, at least in PFS, in the first-line Cabo-Sun trial that led to the extension of cabozantinib's indication to first-line. So there are lots of reasons to potentially give a TKI, but we also have lots of choice. And the choice in the intermediate and poor risk patients is to give them immunotherapy with nivo and ipilimumab. In the good risk patients, there may still be a place to give old-style immunotherapy with interleukin to some patients, because we can produce cures and long-term disease-free intervals in a proportion of them. But the whole thing's been tipped upside down in the last couple of years.